Recognizes Representative Griffith for 5 minutes of questioning. And Mr. Griffith, please remember to unmute.
Thank you very much. I hope I can be heard. I would start by just touching on a couple of points that have been brought up previously. And I know that we're worried about overutilization, but I represent a relatively economically poor area of the mountains of Virginia. And a lot of folks have a hard time getting health care as it is. Telemedicine is a wonderful concept that is helping them greatly. And somebody mentioned telestroke. I was one of the sponsors of that, and it took us a long time to convince people that that would be helpful. So I'm glad that it's working out well. But I will tell you also that I'm worried about and I know we want a glide path, and I recognize that that has merit. But for a lot of my district, even when we get, and we're now deploying low orbit satellite broadband in the district, it's just starting. But even when we get access to that, it's $100 a month, and a lot of the folks in my district can't afford $100 a month. So we have to try to figure out how to do that, because for a lot of these people, when it works, the audio makes a lot of sense. So Dr. Resnick, I'd like to learn more about your opinion on audio only versus audio video patient interactions. CMS estimates about 30% of telehealth visits to be audio only, and a recent JAMA study of California-based FQHCs found that audio only visits accounted for nearly half of all telehealth visits. When is it appropriate to use audio only?
Thanks, Congressman. I would say it's interesting. It's typically not our first choice, but it has been a lifeline for patients in rural areas and disadvantaged patients, as you've heard from some of my colleagues today. I'm surprised at how many of my patients don't have broadband access, even in a technologically advanced Bay Area like where I live, and I know it's true in rural areas as well. Sometimes it's just an emergency backup. A patient will be with you on a video visit and something will go wrong with their technology. You know, who among us today has not had a Zoom or Microsoft Teams meeting go awry, where we end up using the phone as a backup, and being able to have that be a covered service is important. We have entire Native American reservations in the United States where there's no broadband access. We have Black and Brown communities who particularly have less broadband access. So I think while we wouldn't want to go to it as a first choice for any particular patient population, any arbitrary end to it as a backup option would particularly harm disadvantaged patients. And that would leave me worried for the future and our work on disparities for those patients.
And I would agree, sometimes that problem exists in areas you wouldn't expect, because just a few miles away from Virginia Tech, a highly wired community, are pockets where we currently don't have any broadband. Now, some of those folks could afford it once we get the satellite broadband going, but they're not able to now. And I do appreciate that. So do you believe it's appropriate for providers to receive a lower reimbursement rate for audio-only visits compared to the audio-video visits?
I don't. That was in effect in the past and hasn't been true during the pandemic, but a lot of the patients I end up taking care of via audio only are just as sick as the person I saw before via video. The care is congruent. You know, the audio visit in itself is not a service to be valued differently. We think of it as just another method to deliver care. And the value of that service should depend on how long it takes me and how sick the patient is, just like any other service. From an overhead standpoint, I'm still maintaining my entire office and my office staff, the nurse who calls the patient in advance to do the med reconciliation, the backup space to bring the patient in if they need to come in person. So unlike remote patient monitoring and other things where it's not equivalent to an in-person service, it's a totally newly defined different thing that needs to be valued. I see it as equivalent.
Let me get one more question, and I appreciate that. I hate to cut you off, but I'm running out of time. Many devices that we use in telemedicine are able to operate entirely on 2G cellular networks, and this helps for a lot of folks in areas that don't have better service. These devices can remotely monitor things like blood pressure, etc. Do any of you, and this will be for anybody, do any of you know of any capabilities that are lacking among 2G capable devices? I'll open it up to any of the witnesses, but I only have 26 seconds. Does that mean that everything you know of applies to 2G, or you just don't have the knowledge base to answer? Which is fine. I mean, we can't know everything.
You have a bunch of dumb docs here. We don't know about 2G. I think is the key point.
Happy to get back to you on that one.
I appreciate that. And look, I understand that's why I'm asking the question. I don't know the answer either, but appreciate you all being here today. And thank you very much, Madam Chair, and I yield back.
Thank you. The gentleman yields back. And